We differentiated between various bone and joint infections. We listed common microorganisms associated with vertebral osteomyelitis or prosthetic joint infection. Now, given a patient case, select effective drug therapy for treatment of bone and joint infection. Let's start with native vertebral osteomyelitis. The goal of therapy is eradication of infection, restoration of function, and pain relief. The 2015 IDSA guidelines recommend that for patients with normal and stable neurologic examination and stable hemodynamics, it's actually recommended to hold empiric antimicrobial therapy until microbiologic diagnosis is established. What I mean is that you can order the cultures and then you can actually wait for the results of the cultures to come back and hold off antibiotics for as much as 1 to 2 weeks. Now, in patients with neurologic compromise, for example, those who have paralysis because the spinal cord is involved, it is recommended to make immediate surgical intervention as well as immediate initiation of empiric antimicrobial therapy. So what this means is that we should still attempt to get cultures, but we do not have to wait for the culture results to come back. So we can actually start empiric therapy based on suspected organism. And in patients with hemodynamic instability, sepsis, septic shock, or severe or progressive neurologic symptoms, it is recommended to initiate empiric antimicrobial therapy in conjunction with an attempt at establishing a microbiologic diagnosis. In other words, if it's taking a long time to get the cultures, it's recommended to not hold off antibiotics and go ahead and give antibiotics before we can even get cultures in patients. So how do we initiate empiric therapy for native vertebral osteomyelitis? It is recommended to cover MRSA, streptococci, and gram-negative bacilli. And keep in mind that common organisms are MRSA, E. coli, and quag-negative staph, as well as streptococci species. IDSA panel specifically said that they are not in favor of routine use of regimens that cover anaerobes or fungal, brucellar, or mycobacterial organism because these pathogens are not as common. Now, the options that they did recommend include vancomycin plus a third generation cephalosporin. So the vancomycin will cover MRSA as well as streptococci, and then a third generation cephalosporin such as ceftriaxone will take care of the gram-negative bacilli as well as streptococci. Now, if your third generation cephalosporin is ceftazidime, for example, then it covers pseudomonas, whereas ceftriaxone does not. So in general, if the patient does not have risk factor for pseudomonal, it's not really necessary to cover it. Now, if you suspect that your patient can actually have pseudomonal infection, then a vancomycin plus a fourth generation cephalosporin like cefepime would be recommended. Unless you're using ceftazidime as a third generation cephalosporin, which would cover pseudomonas empirically. And of course, if you suspect multi-drug resistant pseudomonas in your patient, then your option would be carbapenem, with the exception of ertapenem because ertapenem does not cover pseudomonas. And for those who have anaphylactic beta-lactam allergy, we can replace beta-lactams with fluoroquinolone, as well as those who cannot tolerate vancomycin, they can actually receive daptomycin instead. Now keep in mind that early switch to an oral regimen may be safe provided that C-reactive protein has decreased and epidural or paravertebral abscesses of significant size have been drained. So basically that will indicate source control. Now once the culture results come back, then it's important to switch empiric therapy to pathogen-directed therapy. And here are the recommendations for specific pathogens. For MSSA, nafcillin, oxacillin, and cefazolin are drugs of choice, as well as for osteomyelitis specifically, ceftriaxone has been compared to oxacillin and was shown to have equivalent efficacy. And the reason ceftriaxone is listed here, even though it's broader in spectrum of activity, is that because for osteomyelitis we have to treat patients long term, some of these patients may have to go home on IV antibiotics, and the convenience of ceftriaxone is that it is administered once a day. So that would make it ideal for outpatient therapy. Whereas cefazolin will have to be dosed every 8 hours in someone with normal renal function, and oxacillin and nafcillin will be dosed every 4 to 6 hours. Alternatively, if the patient cannot tolerate the first choice, the alternative recommendations are vancomycin, daptomycin, linezolid, levofloxacin plus rifampin, as well as clindamycin. And these are alternatives because the first choice are more effective as well as safer. Now, the reason levofloxacin and rifampin is a two-drug combination is because that is how this combination was studied in clinical study. Now, for MSSA specifically, beta-lactams are superior to vancomycin, so it's always important to not use vancomycin for MSSA unless the patient had severe type 1 beta-lactam allergy, because by far beta-lactams are superior in eradicating MSSA. Now, when it comes to MRSA, that's when vancomycin becomes drugs of choice, because most beta-lactams are not active against MRSA, and ceftaroline, which does have activity against MRSA, has not been extensively studied for osteomyelitis. So vancomycin is very safe and effective for osteomyelitis due to MRSA. Now, alternatively, we also have the option with daptomycin, linezolid, and of course the combination of levofloxacin and rifampin. For enterococcus that's penicillin susceptible, either penicillin or ampicillin is drug of choice. And of course, alternatively, we can use vancomycin, daptomycin, and linezolid. Penicillin susceptible enterococcus is unlikely to be vancomycin resistant. However, when it comes to enterococcus that is penicillin resistant, it sometimes can be also resistant to vancomycin. At that point, daptomycin and linezolid become drug of choice. Otherwise, if enterococcus that's resistant to penicillin is susceptible to vancomycin, vancomycin would still be the drug of choice. For Pseudomonas, cefepime is the drug of choice. Of course, if we're talking about multi-drug resistant Pseudomonas, then carbapenems might be the option, because this could be resistant to cefepime or piptazo. The reason piptazo or piperacillin tazobactam zosyn is not listed here is because these agents have more extensively been studied for this indication of osteomyelitis. And compared to cefepime, piptazo has significantly less bone penetration. Now, for Enterobacterialis, cefepime or erdapenem have extensively been studied, and there are drug of choice, even though cefepime is very broad spectrum because of extensive data for its efficacy is listed here. And alternatively, we have ciprofloxacin. For beta hemolytic streptococci, we have penicillin and ceftriaxone as first choice, and vancomycin will be an alternative. And you can see the first choice for some of the other causative pathogens. For Brucella species, which is extremely uncommon, the only two options are combination of either doxycycline and streptomycin, or combination of doxycycline plus rifampin. In particular, pay attention to the duration of therapy, because Brucella species, although uncommon, they are rather more difficult to eradicate, so often a very long duration of therapy is recommended. For native vertebral osteomyelitis specifically, total duration of 6 weeks of parenteral or highly bioavailable oral antimicrobial therapy for most patients with bacterial NVO is recommended. Of course, a total duration of 3 months of antimicrobial therapy is recommended for patients with NVO due to Brucella species. The rationale behind the prolonged duration mostly stems from the limited bone penetration of most antibiotics in patients with NVO, the need for several weeks for bone to revascularize following surgery, and the limited experience derived from trials in pediatric patients with hematogenous long bone osteomyelitis. Now, for prosthetic joint infections, the goal of therapy is, of course, to cure the infection and prevent recurrence, but also to ensure a pain-free and functional joint. The use of antimicrobial agents alone without surgical intervention is often unsuccessful because of the presence of a foreign object. Source control becomes extremely important. Therefore, the goals are best achieved by a multidisciplinary team of orthopedic surgeons, infectious disease specialists, a clinical microbiologist, and of course, a pharmacist. Now, for prosthetic joint infections, source control is extremely important, so surgical intervention is key. However, some patients may not qualify and may not be a candidate for operation. If so, those patients may need long-term antimicrobial suppression because of lack of source control, and sometimes this could be lifetime. However, those who do qualify to receive surgical intervention, resection arthroplasty can either occur as a 1 or 2-stage exchange. In 1-stage exchange, basically the hardware is removed and replaced with a new one in the same procedure. In a 2-stage exchange, first in the first phase, the hardware is removed and then followed by a period of systemic antimicrobial agents to make sure that the area is not contaminated, so that when the new device is replaced, the new device does not get contaminated. Now, during that period that the patient is getting systemic antimicrobial agent, a spacer which is impregnated with antimicrobial is placed, just because the hardware has been removed and there's going to be a space in there. So there will be a spacer in place until the second stage where a new hardware is placed permanently. And typically, the way that it's decided whether the hardware should be removed or not has to do with the duration of symptoms. So typically, if the symptoms are greater than 3 weeks, or if the hardware is actually older than 30 days, then it's actually removed and replaced with a new one. Otherwise, if the symptoms have been less than 3 weeks or if the hardware is pretty young, less than 30 days, debridement and retention will likely be enough. Now, antimicrobial therapy for prosthetic joint infection is pathogen specific rather than empiric. And what that means is that the antibiotics are actually selected based on the culture that we receive. And there are 2 ways to receive cultures. So if there is a diagnostic arthrocentesis performed, that's when we get synovial fluid and we can actually culture, and based on the results we can choose antimicrobials. Or if the patient requires surgery, during surgery tissue samples may be collected and then sent to the microbiology lab for culture, and then based on the results we can choose antibiotics or any antimicrobial that's needed. Now, for patients who get debridement but they have retention of the prosthesis, long duration of antibiotics are needed because with the retention of prosthesis, the biofilm will be present. Now, for prosthetic joint infection due to Staphylococcus aureus, so either MSSA or MRSA, which would be based on the results of the culture, IV antimicrobial therapy is absolutely essential for initial therapy. And this has to be in combination with rifampin because of the risk of presence of biofilm. And what rifampin will do is that will actually help dissolve the biofilm that would allow for both the rifampin and whatever we use for MSSA and MRSA to penetrate the source of infection, which is on the prosthesis. And this combination will actually have to be continued in the patient for 2 to 6 weeks. Rifampin is only available as PO, so the rifampin portion will be oral, whereas for the coverage of MSSA or MRSA, it has to be IV antimicrobial therapy because we want excellent bioavailability of these antimicrobials. And then once the 2 to 6 weeks, and the 2 to 6 weeks is decided based on how the patient progresses, we can basically trend CRP, C-reactive protein, and based on the patient's response, we can decide how many weeks is needed. But regardless, beyond the 6 weeks, the patient needs to be switched to oral antimicrobial therapy for a certain duration of time. And that depends on the type of arthroplasty that the patient receives. So either total hip arthroplasty or total knee arthroplasty. So the knee would require 6 months of oral antimicrobial therapy, whereas the hip would require 3 months. And for this phase, we want antimicrobials that are extremely bioavailable. So fluoroquinolones are by far the most bioavailable antibiotics. So ciprofloxacin or levofloxacin would be the drug of choice. Now, this is assuming that the culture results show susceptibility, so they must be susceptible. So sometimes ciprofloxacin is not excellent for MSSA. Levofloxacin is more likely to have coverage against MSSA. And then second line agents include trimsulfa, minocycline, doxycycline, cephalexin, and dicloxacillin. So if this happens to be MRSA, we may need to use one of these second agents that are active against MRSA. So trimsulfa, minocycline, doxycycline are typically active against MRSA. Now, if the patient cannot tolerate rifampin, whether because of allergy or toxicity or intolerance, and I should disclose that rifampin is a strong inducer of CYP3A4, so there may be drug interactions preventing the patient to take it. At that point, the IV and antimicrobial therapy for the empiric therapy would actually have to be at least 4 weeks instead of 2 to 6 weeks. So it would be 4 to 6 weeks as monotherapy. Now, for patients who need indefinite chronic oral antimicrobial suppression, the options include, oral options I should say, include cephalexin, dicloxacillin, trimsulfa, minocycline based on in vitro susceptibility. And this may be necessary for patients who cannot get arthroplasty or amputation, either because they're unsuitable or because sometimes they refuse to get amputation or arthroplasty. And I should emphasize that rifampin monotherapy is not recommended. It is never appropriate to use rifampin monotherapy for staphylococcal infections, because when we use rifampin as monotherapy, staphylococcus develops resistance to rifampin very quickly. Now, for prosthetic joint infection due to other organisms other than staphylococcus, it does not have to be IV therapy for empiric treatment. So it can either be IV or highly bioavailable oral antimicrobial therapy for 4 to 6 weeks based on the culture results. Now, the treatment that I have discussed so far was assuming that the patient actually received debridement and retention of the prosthesis. Now, if the patient receives resection arthroplastic with or without reimplantation, this basically means that the source of the infection is removed, so all of the biofilm is removed. So for these patients, rifampin is not needed because there is no biofilm. By resection, basically the source has been removed. And then the pathogen-specific IV or highly bioavailable oral antimicrobial therapy will be needed for 4 to 6 weeks. And for patients who receive amputation, these are the patients who receive the maximum amount of source control. And the way that we find out that if they received absolute complete source control is that we actually wait for culture results 24 to 48 hours after imputation. And this is basically a culture from residual infected bone and soft tissue. So whatever tissue they actually remove surgically, from the margins, they would actually take a sample and culture to see if the margin around the area after amputation is actually infected or not. So antibiotics can be discontinued after 48 hours if nothing is growing. If something does grow on the margins, then antimicrobial therapy based on the culture results are needed for 4 to 6 weeks.